Hey all, my name is Kevin Tan, and this summer I work with Dr. Rin. Today I'll be talking about the characterization of the immune signature of cardiac remodeling post-myocardial infarction. Okay, so just to provide some background, a myocardial infarction, colloquially known as a heart attack, is when blood flow is suddenly cut off from the heart, causing tissue damage due to a lack of oxygen. This is often precipitated by a buildup of cholesterol and plaque in the blood vessels that supply the heart, specifically the coronary arteries. This buildup on the vessel walls is called atherosclerosis. You can see the exact mechanism of a heart attack here on the right. Plaque ruptures and causes a clot in the artery, blocking blood flow to the heart and causing necrosis. Cardiac remodeling is defined as the collection of molecular, cellular, and interstitial disturbances that are clinically manifested as changes in the geometry, size, and function of the heart after injury. Early in the heart attack disease process, remodeling can actually be adaptive, allowing the heart to compensate for any damage sustained. But if this initial process is continued, the alterations in ventricular morphology may become exaggerated, resulting in decreased cardiac function and ensuing heart failure. You can see the effect of pathological remodeling in this diagram. On the left, you see the initial infarction here in the left ventricle, while the model on the right depicts the effect of adverse remodeling. You can very clearly see that the left ventricle here is deformed. Left ventricular dilation is when the left ventricle stretches, thins out, and becomes less elliptical, instead forming a more globular shape. Now, whether the heart fully recovers from a heart attack or not is dependent on several well-known factors, such as the duration of ischemia, the lack of oxygen, and door to balloon time, which is the time between the onset of symptoms and performing an angioplasty to open up the blocked arteries. That said, how the immune system contributes to this recovery process is understudied, which is what we're interested in. Importantly, a deeper understanding of remodeling post-MI in tandem with the immune system may support the development of novel cardiac reparative management strategies. So the primary goals of this clinical trial were to, number one, characterize changes in the proteomic and transcriptomic profile of immune cells after an MI. The protein and expression profile of immune cells is what makes up the immune signature that we're interested in. And two, to correlate the immune signature gleaned from step one with cardiac remodeling, which is measured by imaging. This is a prospective case control study, which is a kind of observational study design that compares two cohorts. In this case, we are comparing patients who are at risk of heart attack with a baseline of CAD, the controls, with those who have recently suffered a heart attack, the cases. The prospective aspect of the study means that we recruit patients to the study and then wait for outcomes, which in this case is cardiac remodeling. These outcomes are then related to suspected risk or protection factors, which in this case is the immune signature. A major role I had in the study was to direct the clinical trial recruitment process. We recruited patients from the Palo Alto VA. So I'm just going to briefly go over the various inclusion and exclusion criteria that were used for the recruitment of control patients. Inclusion criteria included things like having a normal ejection fraction, which is a measure of cardiac function, and being under the age of 90. This is because for proper analysis, we want to match patient characteristics in the control group as closely as possible to the case group, and it's far easier to have younger patients come in for multiple visits for imaging. Notable exclusion criteria included having autoimmune disease and being on immunosuppressants. Of course, this is because we are looking at their immune signature and don't want any confounding factors. Now I'll walk you through the workflow for the recruitment process. Each week, I would look at patients who had diagnostic cath appointments scheduled for the following week. Taking into account the aforementioned inclusion and exclusion criteria, I would curate a list of potential recruits and record their contact info. I would then call up each patient, provide a synopsis of the study, and ask if they would be open to talking about it more on the day of their entry. Next, I would go to the VA on the day the procedure was scheduled to be held, explain the study more in depth, and have them fill out the consent form. Lastly, we would collect their blood from 3 sites. We collected peripheral blood, both venous and arterial. We also collected coronary blood, ideally from the diseased vessel in the heart. The blood would then be brought back to Stanford to store and profile, and I would conduct a medical records review, recording clinically relevant factors such as comorbidities, lab values, results of their cath, etc., and insert it into a spreadsheet for later analysis. So I just talked about the work that I personally did this summer, which was the recruitment of control patients. In regards to next steps, as we continue the study and get more case patients, we will use imaging, in particular echo and MRI, to follow their heart remodeling. For example, we might order an echo 1 day post-MI, 1 week post-MI, and 3 months post-MI to see the progression. We'd also have a subset of patients get MRIs, which is the gold standard for cardiac imaging, as it's more accurate and provides better image quality, as you can see here. But of course, it is more expensive and less accessible. We would then correlate remodeling with the immune signature elucidated from blood profiling. And that's all I have for today. And I just want to give a big thank you to Dr. Wynn for all of the guidance and support she provided this summer. I am so appreciative for the mentorship.